Hi everyone, good morning, good afternoon, good evening. I would like to thank all three experts, Professor Shafi, Dr. Zubin, and John for joining us. And let's give a round of applause to Dr. Zubin. Welcome on the stage.
Thanks very much, CK. Nice to be speaking with you, John, as well. Thank you for all the emoticons. That's great. I think just before I start, let me just briefly introduce myself. My name is Zubin. I'm an orthopedic surgeon by training. I now only practice part-time. I see patients in clinics. I use a lot of teleconsultations and digital health. I lead the PwC Health Industries practice for PwC Singapore, as well as our Southeast Asia consulting business. And I'm quite heavily involved in the health tech ecosystem as well. That's really where my passion is, digital health and medical education. I think Shafi will be joining a little bit later on. Work closely with Shafi on a number of things. So excited to be here. Great. So I'm going to start today by talking a little bit about telemedicine and just the growing scene in Asia, but really it's globally as well. Okay. So the first thing I thought, maybe let's put things into perspective. And I know you all can't respond, but if I asked a few questions like, what if I told you that in the future hospitals may not exist? Would the majority of you think that I'm crazy? Would the majority of you agree with this statement? And if I went on and said, well, what if I told you that in the future hospitals that do exist may not have any patients? Is that a little bit more realistic? Is that a little bit more crazy? And if we take this further, what if I told you that in the future countries like Bolivia may become global role models when it comes to digital hospitals? Or that in the future, surgery and surgical education may become democratized? What if I told you that in the future, augmented, virtual, and mixed reality may actually play a significant role in preoperative planning, as well as in the intraoperative space in the operating theater? What if I took it one step further and asked, what if in the future, surgeons may even be using these modalities to actually teach our colleagues around the world how to operate and actually take them through live cases remotely? What if I told you that data exchange may become the norm with benefits to all stakeholders? There's a lot of talk today about data and clinical and health data. What if there are benefits to all stakeholders? Can we unlock the value of data? And then what if I told you that clinically validated digital twins of the human body may exist in the future to help us do research on the drug scene, to help us actually determine outcomes and make treatment plans? What if I told you that drones may actually play a pivotal role in saving lives, especially in emergencies? Or that in the future, health tech, including artificial intelligence and wearable technology, may completely revolutionize the way we deliver care? What if I told you that new entrants, or at least partnerships with these new entrants, and I'll talk about new entrants in a while, may have a greater impact than the larger dominating corporates that we hear of today? What if I told you that telemedicine may actually provide quality care that is more affordable and more accessible than traditional care models, and in addition, have a better return on investment? At the end of the day, one of my favorite quotes is what you see here. And it was Bill Gates who said, we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. And I think for these reasons, it's extremely important that we all come together and agree that we must reimagine healthcare as we know it. So I talked about new entrants earlier. PwC some years ago coined the term the new health economy. I want to just spend a couple of seconds on this. Now, what we define as the new health economy is really an era of health where we see new entrants. And what do I mean by new entrants? I mean smaller players, not the big corporates, startups, players who have traditionally not been in the healthcare space, using new technology, new business models, new ways of financing themselves to ultimately come up with new healthcare delivery models. This is what we're seeing in the new health economy. So when I asked you those questions earlier, these are just some examples that already exist. So in the future, maybe hospitals don't exist. We're already going there. These images were from a couple of years ago, back in 2017 in the US. Hospital that doesn't have any patients. In China, there was a hospital called Ningbo, and that was already 5 years ago. Pros and cons exist. Don't have enough time to go through all of them, but this is nothing new. Shafi, who you'll hear from later, has a hospital that's been named after him in Bolivia, first digital hospital in Bolivia, and some really cool things that they're doing there. So you think about, emerging economies, they're actually going to be leapfrogging the developed countries. About democratization of surgery. Again, Shafi here with another one of our friends, Raphael from the United States. The two of them are both the world's most watched surgeons. They're democratizing surgery and education, and they're streaming live surgeries and teaching students up to in excess of 100,000 at a time. These figures were from 4, 5, 6 years ago. But in the recent past, they're teaching 170, 180,000 students globally live in real time. AR, VR, and MR. We think that these pictures are actually futuristic, but no, they're here today. The one on the left has already gotten FDA approval for some of their products and technology. The one on the right sought approval and got it in 2018. This all exists today. Again, another example of Shafi. I wish he was here. I don't know if he's joined yet. Yeah, Shafi's been using technology like this to help colleagues in distant locations actually go through cases, whether it's in Syria, Palestine, etc. And I guess he can talk a little bit more about that when he comes on. From a data point of view, years ago, we built a data interchange at PwC in the US that is essentially a centralized, HIPAA-compliant, and high-trust certified data exchange. This was built for one of the biggest cancer centers in the United States. And since then, it's been used to lower the incidence and prevalence of diabetes in places like Texas, southern rural Texas, which has the poorest socio-demographic population in all of America. So if you unlock the power of data, it's amazing what you can do. From a digital twin perspective, again, at PwC years ago, we built the world's first clinically validated digital twin of the human body. Many uses exist, from pharma to insurance and medtech. So again, nothing new. When we talk about drones, I think some of you might have seen the images at the bottom there. There's a great video on YouTube. If you actually just Google Amsterdam drone or cardiac defibrillator drone. This drone has a built-in cardiac defibrillator that reaches patients during a cardiac arrest within 12 square kilometers in less than 60 seconds. It uses telemedicine and teleconsultations. The screen actually pops up and you speak to either a paramedic or health professional, so you can help use the defibrillator. These pictures that you see all exist today already. AI in technology, teleconsultation, SpeedDoc, a local Singapore company, Babylon, which is now global and is based out of Singapore for this part of the world. All companies are looking at telehealth solutions in some way or form. So it's really nothing new. I talked about new entrants earlier. This was really an example when I talk about new entrants versus the big corporates. New entrants like Remedio or Medios, companies both based out of Singapore and India, had better results than what Google DeepMind was doing in diabetic retinopathy. Amazing what some of the new entrants have been doing. From a teleconsult perspective, companies like MyDoc, which I do declare I've been involved in since it's founded, MedShare out of the UK, various platforms exist and are being used Singapore, UK, and in emerging markets for years and years now. This picture, I was hoping Shafi would have joined us. Shafi actually gave me this picture sometime last year when he was visiting, I think it was, can't remember which country it was actually, but the point is this isn't just happening in developed countries, it's happening in emerging markets right now today. So I think before we start, maybe a little quick brief history lesson. So if you look at this painting, I'll give you a bit of history. This really depicts ambulatory care and the term flying ambulances. Historically, Dominique Jean Larrey, who was the physician to Napoleon, actually used horses in those days to take patients back to medical tents. And actually, that's how the term flying ambulances came about, because of the horse-drawn carriages. And if we think about it from a historical perspective, we have gone really from flying ambulances to remote care delivery. If you look here on the left, historically, we've gone to choppers and planes. And now what are we doing? We're providing care from thousands and thousands of miles away. Nothing really new. The advent of this technology has already changed the face of care, as I've said, in previously challenging to access environments. disaster-stricken areas where there are earthquakes, tornadoes, hurricanes, where infrastructure has been destroyed so you can't reach there, you can still provide care in these environments, and telehealth allows us to do so. When you talk about action and monitoring, we can use telehealth solutions to provide agile, rapid, and sustainable responses, and use all sorts of parameters to actually determine what we're looking at. I said that telemedicine is nothing new. If you think about it, when I get into discussions with colleagues and naysayers about telehealth and telemedicine, the truth is we have been using telemedicine for decades and decades. If you think about it, back in the day, before even when we used to use pagers, right? No mobile phones in hospitals. We used to bump into colleagues in the corridor. We used to call them corridor consults. Essentially, you'd be getting second opinions from colleagues. You'd pick up the phone, you'd phone a friend, ask for an opinion, you'd meet them in the corridor, you'd ask for an opinion. Essentially, that really is the same as what we do in teleconsultation and telehealth to a certain extent, except that now technology has advanced. I put up this paper back in 2010, so a decade ago, if I think about it. I published a paper when I was working in Ireland, and I entitled it "Orthobot to Your Station." At the time, there was an economic recession in Ireland, and they were trying to cut the time doctors went physically to hospitals on weekends and out of hours to round on their patients. So essentially what I did with a colleague is use the robot, who was 5'7", and I controlled the robot from my home, from a laptop. And, it turned out to have great results. Of course, there were shortcomings, but the patients loved it. And there was a lot we could do with it, because although when we talk about telemedicine, you might need physical touch, but not always. There's still a lot you can do with history and just observation. This story I wanted to share, and I think Shafi and John, maybe you heard this story before as well. There was a very famous doctor in the UK, David Knotts, and he was at a consultant's dinner for the Chelsea and Westminster Hospital. And as he sat down at dinner, and I have a friend actually who was at the dinner with him at the time, he checked his phone and he basically had a message that said, "Hi, David, this is an urgent consultation from inside Syria." Attached was a photograph of a man who had been shot in the throat and the stomach. And over the next number of minutes, David received images and questions, because in Syria, the level of training of the doctors isn't like it would be in the developed countries. And this man who had been shot in the throat, the surgeon attending to him took instructions from David, and actually this gentleman was saved. And David went on to explain what to do, what muscles to detach, how to sew up the bullet wound, and how to treat the patient. So again, nothing really new. If we think about it, it goes all the way back to the 70s, right? Telesurgery and teleanesthesia have been around for decades. I think it's just getting a lot of hype now, especially because of COVID, or rather the pandemic situation that we're in. But I just want to reiterate, this is nothing new or revolutionary. It's just being more well accepted today. What is it allowing us to do? It's allowing healthcare professionals to provide consultations from thousands of miles away. It allows us to triage, it avoids transportation issues, it prevents logistics coordination challenges that sometimes don't let patients get to where they need to be. It allows for a very lean structure of an organization, or rather healthcare organization, and we can use it to monitor in both the acute and chronic settings. The Army has been using this as well for triaging their soldiers on site and using real-time monitoring to maintain optimal military performance. And it's pretty amazing what various military forces have been doing. Social media, we talk about teleconsultation, but social media is in some way a teleconsultation as well. You can actually use social media, Twitter in this case of the example that we've put up, to actually predict and report on heart disease rates in a country. If you look at the left, it's based on the death certificates. If you look on the right, it's predicted by Twitter. And you can see awfully similar. I talked about drones earlier, so I won't go on to discuss this any further, but we're using it to provide actual care. We're using it to drop medicines. We're using it to pick up patients and evac them from disaster-stricken areas. So I think, again, years ago, 5 years ago, in an article from Harvard Business Review, it was said that in a few years, the idea of receiving medical treatment exclusively at a doctor's office or hospital will seem quaint. And at the time, certainly in Singapore, when I came back in 2012, people laughed at me. People thought that that is just ridiculous. But if you think about it in a short number of years, that is what has happened. And the headlines here on the right are just some examples how Babylon, highest raise in health tech history, $550 million at a $2 billion plus valuation. MyDoc, Singapore-based, Doctor Anywhere, Singapore-based, Ping An, good doctor out of China, Indonesia, Singapore, many, many examples locally, regionally, and globally. And if you look at health tech investments, the telemedicine and telehealth scene has just absolutely exploded. It's really evolved beyond real-time conference calls or corridor consults, as I was telling you, with doctors, to new technologies allowing remote patient monitoring, right? So the way we look at it, we really think that it can be categorized into three buckets. The first is really an interactive model. The second is where you store information and forward it. And then lastly, remote patient monitoring. And of course, there's a hybrid of all these that exist too. By the way, I'll be sharing these slides with everyone, so I'm not going to go into detail and read line by line during the presentation. If anyone has a question, please jump in. From an Asia perspective, the telemedicine market has grown absolutely exponentially over the last couple of years, but yet there is a large untapped potential across all of Asia and more broadly, ASEAN's. Across the region, as I've said, countries are at different stages of maturity, obviously, in their development. And when I say maturity, I don't necessarily mean that countries that are in a more developing stage are less mature than countries that are not. And we'll talk about that shortly. So I think at the end of the day, changing healthcare needs that are paired with fast-growing technology adoption really creates an opportunity for growth of telemedicine in Asia. We're seeing changing demographics that is not just a regional trend, it is a global trend, right? Aging is a big, big problem. There's still a lot of inaccessible healthcare as greatly improved the world is. We're seeing an increasing penetration of technology. If you just look at countries like Indonesia, Philippines, mobile penetration, even though infrastructure is low, mobile penetration is extremely high. And when that's the case, I guess for those of you in the telecoms business who are on this talk, I've said it for years and years. In fact, I think the telecom companies are in the best position to get involved because they have the medium that can provide telehealth solutions. And then obviously empowered consumers. Today, patients are demanding what they want, where they want it, and how they want it. And we have to cater to those demands. That, I suppose, subsequently fuels the success of telemedicine companies in the region, the examples of what I shared earlier. However, there are still many, many challenges faced by many players in the market today. And again, three buckets that we like to put them in is number one, no surprise, the regulation space and regulatory barriers. Number two, obviously the security concerns. How can you validate? How do you know who you're speaking to is really who you're speaking to? How do you know that the qualification of the person or health professional that you are talking to actually has been validated? And then lastly, international barriers, where examples like countries lacking infrastructure, as I mentioned earlier, lack of technology literacy, or high customer acquisition costs in many cases. But the good thing is that these problems have really prompted governments to recognize the need and implement regulations and laws to support the growth of this industry. So again, just some examples. Back in 2018, our own Singapore Ministry of Health launched the first regulatory sandbox to support the development of telemedicine. This sandbox has now matured, maybe wound up in the next number of months or years, and has achieved a lot, gathered a lot of insights, and has helped mature our telemedicine space in Singapore greatly. In China, health authorities have issued new rules on telemedicine. Japan actually removed barriers to promote the adoption of telemedicine under their 2035 healthcare plan. And South Korea encouraged the introduction of telemedicine among patients for the last 2 years. Countries in the region are the same. A lot of the Ministry of Health in Southeast Asia are starting to implement telemedicine guidelines. So I said earlier that I'll mention just because lack of infrastructure does not necessarily equate to being less mature. So back in 2016, we wrote a report entitled The Digital Healthcare Leap. And in this piece, we mentioned that countries in emerging markets were actually going to leapfrog developed countries like Singapore and countries in the West. And we felt that this was the case for a number of reasons. Number one, they didn't have legacy systems in place or technology systems in place. They didn't have the barriers from a people, process, or technology point of view to overcome. So they literally could adopt new technologies very easily. And then in 2017, we published a follow-up piece on the challenges and solutions to measuring the return on investment. Because a lot of countries and organizations were saying, sure, but the capital expenditure is just too high to actually justify the implementation of these solutions. But actually, that really isn't the case. We looked at a use case actually out of Singapore. And again, I do advise my doc from the beginning, but to avoid any conflict of interest, this was firewalled. I had no access to this data. And actually, the National University of Singapore analyzed the MyDoc data, compared it to Singapore's Health Promotion Board independently, and we got these results. But it is, in essence, we found a return on investment from virtual consults in a health screening initiative in Singapore. And it was found that patients who have a teleconsult are 6 times more likely to follow up than those who were seen in the traditional means. And when calculated, what that equated to in a very small diabetic population is actually the cost savings here, $2.9 million from virtual consults versus $560,000 from a physical consult. So there is a return on investment depending on how you look at it. We then went on in 2018 to host an event called Embracing a Safe Digital Health Future for Singapore with the Singapore Medical Association and MyDoc. And it was very interesting hearing the regulatory, the legal, the ethical concerns from various clinicians and senior stakeholders. So I guess we ask ourselves, what's next for the telemedicine industry in Asia? And then I'll wrap up. Think 3 things: partnerships that go beyond the industry. We just can't succeed in a siloed, fragmented ecosystem like we have been doing for decades. There has to be more regulatory governance and coordination, and machine learning and telemedicine are going to be growing hand in hand. As a clinician, I always come back to patients and have believed that we should use technology to complement our clinical practices, not replace them. And I put that in brackets, at least not yet, because who knows what the future holds in 30, 40, or 50 years. Just want to highlight to clinicians out there that we still do need to be careful. This is not about rushing out there and saying telemedicine and machine learning and AI are the greatest solutions to healthcare's problems. In the UK, Minister Jeremy Hunt actually provided advice, and the headline here catches it on the pun, rash advice, and had said to people publicly that if your child has a rash, you can just Google it and look online, because we've got such long waiting times in A&E. And ultimately, a colleague of mine said that he did come across a parent who did not take their child to the hospital, and the child died because it was a rash from meningitis, but they had looked at it on Google. So we have to be very careful what we do with telemedicine. We're certainly living in a more patient-centric era where patients are empowered. Eric Topol's book, The Patient Will See You Now, I love the title because it really depicts what we're seeing today. The comic in the center is just a joke. That is not what I mean by patient-centered care. But ultimately, the patient will see you now is the era we're living in. Like I said, patients determine who they see, where they see, how they see them. I'm actually in my home and I run teleconsults out of this. This is my office where I'm sitting right now. They do behave as an always-on consumer, and they expect a connected experience. They want to participate in their care. They bring a very innovative appetite to the table, and they can certainly make smarter decisions than ever before, sometimes smarter than even the doctors. And we have to concede that sometimes we may not know all the information that a patient provides us from what they've searched online. Ultimately, I started off talking about the new health economy, and I think these are all parts of the new health economy. But as a clinician, I always think that we have to think about our patients, and it ultimately does come back to our patients. So just to wrap up, at the end of the day, in Singapore, we have national telemedicine guidelines, we have an ethical code and guidelines, and we have a Personal Data Protection Act. I think if we follow what these say and tell us to do, we'll be okay.
thanks for having me. I'm delighted to be here from this office that I've been in for the last 7 months. I do recognise the irony of talking about remote interactions when, you know, the thing I crave most at the moment is some face-to-face contact. But I think that's the same for all of us here. And there's certainly some advantages to our current situation and the ability for us to share some of these insights with people from literally all over the world. So if anyone has dialed in from the USA, I'm really impressed with your commitment. So I head up the digital marketing and digital health group within Pfizer, and it's our responsibility to transform the way that we engage our healthcare professionals and patients through new digital technology communication solutions. And in addition to that, from the digital health perspective, it's about driving adoption of proven digital health tools and services that will improve patient outcomes and the patient experience. So the topic today around telehealth and Pfizer is a really important one to me personally as well. So if I start with this, which obviously Zubin has just covered, but you know, if we reflect back to January of this year, I would have been stood up talking about how these three trends were driving a shift towards more digital solutions and more telehealth solutions. And ultimately, these trends are really important. The fact that the healthcare needs are growing because of the aging population, lots of comorbid conditions that patients are managing now, the increase in patient consumerism, and I think that term sort of captures a number of different pieces within the patient space. So one, you know, patients are taking a lot more control over their self-management, but secondly, the experience of healthcare is now becoming a lot more digital. And our patients are obviously experiencing digital in a lot of other industries as well. And potentially, you know, they're recognizing what a good experience looks like and what a bad experience looks like. And that reflects then on the way that we are delivering healthcare. But perhaps one of the most important trends for us as an industry, in the pharmaceutical industry, is this gradual move from a volume to a value-based reimbursement system. So we know that in the near future, many healthcare systems will reimburse based on the outcomes that we've provided for patients rather than the number of pills that have been procured. And when you start to think about outcomes and being paid based on outcomes, then digital technology becomes really critical, because we know that it's not just the medicine that leads to the outcome for the patient. It's the whole suite of solutions, from prevention of disease to disease awareness in the early stages, to diagnosis, to treatment, and then ongoing management. There are elements within all of that patient journey that lead to differences in patient outcomes. And if digital is able to both help improve the experience that patients have at each of those parts of the journey, or even capture the patient reported outcomes so that we can prove the value at the end of the experience, then we're going to be in a much better place. Now, obviously, January of this year, none of us really expected the level of disruption that the global pandemic would bring. And I think really what it's done for us, at least in Pfizer, is really bring these trends into sharp focus. So these trends were driving incremental improvements and adoption of telehealth solutions across all of our markets and across all of our therapy areas, but it was gradual and incremental. I was just talking to Shafi and Zubin about the fact that, you know, we've really seen transformation in the last 6 months equal to probably 10 years of hard work. And now we're seeing a must do rather than a should do mentality popping up. So at Pfizer, really, our approach has been to try and really understand these trends, understand how they will shape the way that healthcare professionals and patients are experiencing healthcare, and then look at what we can provide as a large corporate and a leader in the healthcare industry to help improve the patient experience and drive better patient outcomes. We have a purpose which is around breakthroughs that change patients' lives. And for the last 50 years, our purpose would have been about bringing breakthroughs in terms of clinical development and manufacture of medicines that can change patients' lives. But as I've just said, these breakthroughs that change patients' lives now for us are all about driving better health outcomes and improved patient experiences. And so digital solutions become now some of those breakthroughs that could genuinely change patients' lives. And so I'm actually here representing our Digital Innovation Lab today at Pfizer. And this is a specific group within Pfizer that has a responsibility around driving transformational digital capabilities to enable drug discovery, accelerate clinical development, enhance patient and provider engagement, and improve outcomes for patients globally. And what this is basically a central group that work with both the clinical development group and our commercial businesses. And they identify what are the big challenges that are facing both our healthcare professional customers and patients right now in the way that they experience healthcare. And then to bring those challenges forwards with investment and resources to help really focus our efforts on solving some of those challenges. At the other end of the spectrum, we also have an ecosystem network called the Healthcare Hub program. And this is basically a number of colleagues spread across the world in various different countries that have a passion and interest in the healthcare transformation space. And it's their role to basically connect with all of the stakeholders, the entrepreneurs, and the tech companies in their markets to explore opportunities. And then essentially in the middle, what we have is this meeting of both the big global priorities, which the Digital Innovation Lab drive, and then the ecosystem network. And so essentially what we're trying to do is bring the outside in and bring the inside out. So I just wanted to touch on a couple of examples. These are examples that are already reported in the press. So if you're interested in getting more information, you should be able to find information on these if you Google them. But what we're looking for is essentially solutions right across the patient journey, from prevention through to long-term management. So some of the examples in the prevention space where we've been working with AI companies or NLP companies to develop chatbots that can help coach people in taking healthy decisions about their life. So in particular, smoking cessation, helping connect citizens to healthcare professionals to get more support in their quit attempts, and also helping patients once they've been prescribed medicines or they've taken the decision to use an intervention to help them quit smoking, provide them that coaching and support that will help them drive a better outcome from that intervention. Then in the diagnosis space, this is perhaps a newer area for us. We are interested in the area of cardiac arrhythmia and ensuring that patients that suffer from cardiac arrhythmia are connected with healthcare professionals to receive treatment as quickly as possible to prevent as many strokes as possible. And in this case, the device that you can see on there is a device called Cortrium, which is a startup that we've been working with for many years in Germany. It's a Danish startup. And in this case, Cortrium have developed a device that can measure heart rhythm and determine cardiac arrhythmias remotely through a patch. There's obviously many other solutions like this available, and we were actually working with a number of different providers of this. And this is about basically ensuring that healthcare professionals are aware of these technologies and facilitating these companies to drive adoption of this type of technology. In the treatment space, this is an in-house developed piece which is for cancer patients, and it's about using digital technology to help a patient through their cancer treatment journey by providing tools like an ability to record questions that they have for their physician, track their symptoms over time so that they can discuss those with their physicians, resources to help them discuss their condition with their relatives and friends and family, and also be able to ask for help from a network of their friends and family with activities of daily living that are causing them problems. The last example is one dear to my heart that I've been involved in for a number of years, which is the BeLive device, which we launched in Brazil a number of years ago. And this was essentially a partnership with a startup that had a wearable. And we found out from a lot of market research with patients that patients were often asked when they were suffering from chronic pain how their pain was today, or how their pain was yesterday. But in those consultations with the healthcare professional, what they really wanted to know was, how's your pain been over 3 months, 6 months? Is it improving? And are my symptoms of anxiety or sleep quality also being impacted by the chronic pain that I'm experiencing? So we set about basically developing a device that would allow patients to track and manage and record their symptoms over time for improving the patient healthcare professional consultation, so that essentially the patient could then show them their results over time, which would allow their healthcare professional to make more informed decisions about their care. So this is not an exhaustive list at all. These are just some of the key examples that we've got across many of the patient journeys. But hopefully over the course of the next couple of years, you're going to hear a lot more about the initiatives that we're working on in this space. And obviously the whole industry is working in this space to drive better outcomes for patients from our medicines. The last piece I wanted to touch on was the Healthcare FinTech Alliance. So I talked at the beginning of the presentation about some of the partnerships that we're developing, because we see this as a team game. So Pfizer doesn't have a lot of the technology capabilities that some of the entrepreneurs or tech companies have. But what we do have is a wealth of experience in how to drive transformational change within the health system with respect to medicines. We've been doing that for many years. And so we are forming these partnerships around the world to help accelerate digital innovation in the health tech space. And this is a really nice example for this region in particular, which was launched back in July the 6th. You can read about it on the Healthcare FinTech Alliance website, which you can see on there. But this is a partnership between Alibaba Cloud, Pfizer, the FinTech Academy, and then our partners, Access Health International. Essentially, we're all bringing our experience to the table with our different perspectives. So Alibaba Cloud is bringing their experience in the AI and cloud technology space. We're bringing our healthcare experience from a global healthcare company point of view. And the FinTech Academy is helping to shape companies for success in the future. So by bringing them forwards through an accelerator type program. And the aim is to establish a Southeast Asia Center of Excellence or Innovation, in Singapore, that aims to create a healthcare technology ecosystem. There are a number of focus areas for the Healthcare FinTech Alliance, but a big one is around healthcare affordability, which we've heard from Zubin's presentation is a challenge in this area. And we're about enhancing the patient journey and treatment outcomes to improve overall the quality of life. Now, the reason that this is a really timely presentation is we have a pitch competition running right now as part of the Healthcare FinTech Alliance. You can see the closing date is August the 30th, and we have two key challenges. One is to maximize the reach and efficiency of patient support programs via technology advances. And then the other one is all around access and affordability to medicines and quality healthcare via innovative financing initiatives. And you can see that there are various prizes on offer for the winners of that challenge, from funding to mentorship to cloud support, etc. So the closing date is very soon. So again, please have a look at the website for more information there. So just wanted to leave you finally with one comment that came from Terry Jones from Travelocity. And he said that if you don't like change, you'll like irrelevance even less. So essentially what this program is at Pfizer, and the way that we're now thinking about telehealth, is we really need to adapt, and we need to change the way that we're operating so that we're not seen as irrelevant in the next 5 to 10 years. And we believe that there is plenty of invention out there, but without adoption, you don't get innovation. And so what our big part to play is driving adoption in this space. So thank you.
Thanks, CK, and thanks for the invitation to be here remotely, I guess, which is obviously the future of healthcare, as John's alluded to already. And I hope I don't become irrelevant in the future. I hope that we can manage the change, as John's described so eloquently. And Zubin gave a great overview on the future of healthcare. I'll concentrate literally on some work that I've been doing, and perhaps just to point to some teasers around what I think the future of healthcare should look like in my own experience. So first of all, we'd like to give you a small glimpse. I've been working with many companies around the world. One of them is Anthem, which is one of the largest insurance providers in the US. I learned a lot about how they manage remote care, how they push care to the community, which has been an ambition to lessen the costs, of course, improve outcomes, and bring care back into the home and community, which makes sense to us. It's about wellness, about well-being, rather than illness. We've been treating sick care for so long, we need to move back to well care. So you play that first video for me. Next slide, CK. So that's kind of a glimpse of the future of the virtual world using augmented displays and information, patient empowerment, and that's data-driven. So that's the kind of where I think we're heading towards. The last quote, of course, is by Abraham Lincoln, is that we're going to have to create the future ourselves going forward. And that hopefully will inspire some people in the audience to think about how they can reimagine healthcare for everybody. So, of course, this is where we are now. This is the kind of historical way. When myself and Zubin were at medical school, we presumably gave the Hippocratic Oath, we qualified, or in fact now it's the kind of slightly change in the oath itself that's given, more aligned to the WHO and the World Health. But actually it's the depiction of human contact, the empathy, how we conduct ourselves in clinical practice. It's being close to our patients, having that closeness, etc., which John alluded to earlier. We're missing the closeness, we're missing the interaction, we all become virtual. But I've argued for a long while, this interaction is too expensive. It's far, people like myself and Zubin, I think Zubin's very expensive when you see him, I think face-to-face, compared to what I offer. But generally, face-to-face is just too expensive. We can't afford it any longer. We have to be remote. And what the pandemic has allowed us to do is drive change. The last 4 months is what I call is a compression of time. Time has been compressed from 2 to 5 years innovation to down to 3 months. The door is open, it's a jar for innovation. And all hospitals and healthcare providers around the world are now actually saying, let's drive hard this innovation. And as people like ourselves who want to innovate, there's an opportunity for all of us to ensure that we create a different kind of healthcare system. And next slide. Let's get back to 1924. Here we are, the Futurist. They're thinking already about a new way of connecting with people. Way before we were thinking about it, they think about radio waves, the radio doctor, looking at mirrors and seeing people remotely. How forward-thinking was that, right? And now we're seeing that revelation in telemedicine that Zubin has already alluded to, and John. Next slide. Of course, we've seen an expansion of telemedicine. Okay, we've seen all companies around the world being using it, and we've seen some companies in America, for example, have increased their telemedicine platform by 4,000, 6,000% over the last 4 months. A year before this crisis, there was over 1 billion global teleconsults. Can you imagine what it's like now, where there's no face-to-face learning? It's driven that change. Here's a company on steroids, Ping An, insurance company in China, who've been doing telemedicine for a while. This was data from a year ago. They actually have over 300 million active users. Can you imagine 300 million? And they're performing over 700,000 consultations per day, virtually. It's just like incredible. And this will only expand as we see the need, the requirement for it. We have the facility, and the online platforms are much more available. Next slide. This is interesting, I thought I'd share with you. A year ago, there's a doctor in the US who was criticized heavily for breaking bad news for a cancer terminal diagnosis on a telemedicine platform. Okay, he was criticized socially from his own medical establishments, but actually now, in the last 3 or 4 months in my own clinics, at the Royal London Hospital I work as a surgeon, I break bad news on a telephone, on telemedicine platform, remotely. Suddenly, it's accepted. So I think we take the patients for granted. They're far more tech savvy than we ever give them credit for. We've been very paternalistic, hierarchical in the way we've managed our healthcare. We know best as doctors. This is what we're going to be doing. Actually, what the pandemic has shown us is drives the other way. Patients demanding quicker, faster access to their knowledge, to see doctors, for their data. And so actually, I think that's changed everything. Next slide, please. So this is, and click again, please. So this is my clinic now. Okay, I do online platform at home with electronic health record, with a virtual smart card, with my iPad on a telemedicine platform, seeing patients remotely, in surgery, remotely, new and old patients. And this has been doing my ward rounds. I've been there for 4 years. 4 years ago, people were a bit surprised I was doing this. Now, it's normal. I see patients going with wards, etc., being remote, avoiding contact with coronavirus, and the patients actually are okay with it. They interact, they think it's okay. They've done a little study around that, saying that how it's acceptable. Next slide. But of course, we've seen Babylon recently buying out a company in the US around this kind of remote consultation. This could be the future of remote care. We don't have to actually have a primary care practice. It could be just a booth which you walk in, you have a telemedicine platform where you speak to a doctor immediately. One of the many millions of patients on the Ping An platform, for example. You can have all your remote monitoring, your stethoscope there, your scanning machines. You could have your blood pressure, pulse, all be measured remotely, for example. That data is then transferred and diagnosis is made. You need some medication? Well, just walk out the door, go next door, pick up your medication immediately, which is in a little bag all ready for you. This is the kind of the concept of remote care, immediate care. It's what human beings are driving for. Why are we waiting weeks and weeks for appointments? Why are we driving weeks for days for getting prescriptions or medication? It makes no sense. You know, we don't wait long for an Uber taxi. We don't wait long for food through Just Eat or Hungry House, whatever. And we don't wait more than a second to watch a film on Netflix. But yet, we're still waiting time for healthcare to be delivered. And that's got to change because we are immediate. The new generation of people, Generation Z, want immediacy. We are very much not tolerant of time. Next slide, please. The world of surgery is going to change. I thought I'd just share a few pictures. This is a great picture from Dubai. Sadly, because of the coronavirus, Dubai Expo 2020 is delayed until next year. This is a glimpse from their museum they created, which you must go and see. It's incredible when it opens next year. This is a picture of the future of surgery. It's augmented, it's virtual, it's 3D printed, it's using images, it's using AI interfaces. It's going to be so incredible. And that future is being walked to us rapidly. Next slide. Some of the work I've been doing just very briefly around AR, VR training, very quickly. All of those things combined, AR, VR, and mixed reality are termed extended reality. And now there's a new word called spatial computing, which allows you to immerse yourself in kind of mixed reality devices. So if you forward one slide, I experimented with these technologies. I thought, let's push the boundary. This is back 6 years ago. I thought about teaching people remotely, i.e. teleeducation, right? I thought it has to be the way forward. Got a Google Glass, and we then configured it, added some software. Next slide. And I streamed live an operation from operating theatre in Royal London around the world. I taught 14,000 people across the globe, so that we need to make healthcare and education more equitable, and democratize the access to healthcare and education. So this is what we did. And we went live, we created a whole platform around learning in telemedicine way before people were thinking about it, because I thought it's about how do we reach people in a way that we can use technology for, that's smart, that's low cost, but has high impact. This is John Sculley. John Sculley was ex-CEO of Apple. Yes, Apple now has become the first company to be worth $2 trillion, I hear yesterday on the news. This was me training John Sculley how to do remote operation in Dubai a few years ago. Next slide. But of course, the world, click that please, thank you. The world is changing to augmented. We're now seeing utilizations in theatre. We're seeing people overlay information, images, CT MRIs in real time, hopefully helping surgeons navigate through an operation. What we're going to get is more data-driven healthcare from surgical aspects. Surgery has been very old-fashioned in the way it delivers its outcomes based on death, mortality, or complication, crude implications. We're having much more data, so you can select the surgeon more precisely about the outcome during the operation. Next slide. And these are the kind of companies that are doing work, overlay information. This is Maki Sakamoto's work in Japan, who's using mixed reality overlay information. Of course, it's crude, it's not good at the moment. It will get better as images are better. Imagine actually operating, being guided through AI, through visuals, like touch surgery, showing where the problems are, where the structures that you have to miss, and then analyzing your performance around good data. So suddenly it becomes a much more sophisticated way of learning and practicing surgery. Next slide. You may think they're far-fetched, but of course not. Last year, the FDA approved 2 of these platforms which you can use today. I wouldn't suggest use the devices and operate, and they're not safe, but to plan, to pre-plan, to augment your practice, absolutely, it makes sense. Next slide. Now we're seeing training change. We're seeing many companies using technology to drive that, to simulate operations. And in the last few months, we've been inundated. In the UK, our surgical trainees have had no surgical experience for 3 or 4 months now. They've stopped. Hardly any operative experience until probably end of the year. So for 6 months, we've got a whole bunch of surgical trainees out there around the world getting no experience. So we've got to think different ways of learning. And actually, next slide, please. We're now looking at different ways of learning. So this is the kind of thing we're looking at where you're practicing simulation. I know Zubin's working with a company in Singapore who are doing amazing simulation work around orthopedic surgery. Next slide, please. And others like also VR, play this video, again, being out there and validating the work, showing that actually you can shorten training, you can improve training and validate the experience of these platforms. Next slide. So augmented world is great. What about the virtual world? So the virtual reality is interesting, of course. Why did the world's first VR surgery back in 2016, 2 years after Google Glass operations? Actually, it's okay being remote. What about bringing people in together? How about breaking that barrier down? And we did the world's first VR surgery in 2016. Next slide. And on that day, I trained 55,000 people across the globe by using just a Google Cardboard, low cost, high-tech technology, so that we can actually really think about how we reimagine people to learn. And this is the medical school at Barts, where I was associate dean, showing what could be achieved. This 360 camera rig allows immersion. People around the world using low-cost technology, a simple VR headset, can actually immerse themselves in operating theatre around the world. Thank you. Thank you. Next slide. Play the video. So this is our company Medical Realities, and we created 3 years ago the world's first surgical learning platform in VR. We worked with many companies, including pharma companies, to create bespoke arrangements around learning. And now, although 2 or 3 years ago it was early, now we see an explosion. The annual growth rate for virtual reality is 16.7%. It's going to be worth $7 billion over the next couple of years. It's a huge industry. And now that this COVID pandemic has now really forced people to think about virtual learning. We create a whole platform around learning, validate it, making sure it's intuitive, and the experience was important to us. Say, how do you create learning on the spectrum of platforms? And we had this whole, we recorded 360 videos, we allowed hotspots to be entertained, we could navigate, we could ask questions, and we could validate the whole experience in VR. This is what's been pushed out now to many medical schools. I've been reached out to many people saying, can we use these learning platforms? We've done some OSCE training, some surgery training, etc. And also some simulation, where you can train people now in this kind of modality, where you can actually now get into operating theatre almost and practice operation. In the last 4 months, they've not had any experience. So now we're seeing quite an interest in these kind of areas of experience, like this, for example, simulation that you create, relearn, learn, etc., at all levels of education. Next slide, please. But of course, my whole ambition is to really transport myself one day. We'll talk about remoteness, we'll talk about telemedicine, but we want to be Star Trek. We want to beam me up Scotty, beam me up Shafi, or beam me up Zubin maybe. And we want to be together. Zubin's all the way in Singapore at the moment. We're great if we can connect with our avatars or real life holograms. So we decided to experiment with this over the last few years. Next slide. So I thought about 2 years ago, I thought, why not do this? Why not use the Microsoft HoloLens to navigate and have three surgeons in the same room together, like an MDT, but using the avatars experience. And so we thought, let's do this, and this is what we did about 2.5 years ago, actually. Yes, next slide.
Hi, everybody. Hi, Shafi. So the HoloLens itself really allows us to reshape the way we connect people, we communicate with people, and also to be used in teaching and training. Initially, when you put the HoloLens on, it feels a bit strange, but actually within a few minutes, it becomes quite normal. You feel as though you're just discussing cases with people in the same room, for example, like we do in normal hospital practice.
We can come in and actually look at this content in full 3D. And obviously, when you're working in this case, the medical field, having a full 3D understanding of a situation, for example, is really much more powerful in solidifying how you want to navigate it in your mind.
Okay, so then I thought, okay, well, that's avatars, blue polygonal images, not real. It's what is connected humans. What is human being all about? What is being human now? Are we changing it? Can we interact with chatbots that John described? Can we interact with avatars, with holograms? So therefore, we're now creating digital humans, of course. This is me being recreated as a virtual human using a process called photogrammetry, a whole bunch of cameras creating a 3D model. Imagine that now being with AI interface, with voice technology, natural voice language, etc. So it's kind of where we're heading towards. So during the pandemic, I thought, let's take it a bit further. Can we do the remote consultation forward a little bit now? Next slide, ZK. Play that.
Hey, Dr. Ahmed, good to see you again. Hey, Harrison, so good to see you. How many you are coming here?
So what we're seeing now is maybe in the UK.
Hi.
Hey guys, I'm in Atlanta right now.
Better interaction going forward, movement. So moving further, needing further forward.
Thanks for joining us. Should we have a look at some images? Help us in this regard.
Hey, this is on a smartphone. You don't have to use mixed reality devices. We'll get a smartphone. We'll make plays and we need to reach people. Next slide, CK.
Shafi, have a look at this.
Yeah, let me have a look over your shoulder. Oh yeah, I see what's going on there. I think I can give some advice, Carl. No problem. Thanks. Okay. So 5G is crucial. 5G is going to create the Internet of Things, Internet of Medical Things. And CK asked me to talk about 5G, but I think that's a talk for another day. I'm happy to talk all about 5G. The Vodafone UK ambassador for Connected Health. And 5G for me is what I call the covalent bond. It's going to bring all those things together we've discussed because of its low latency of 0.1 millisecond, high bandwidth of 2-3 gigabytes per second download speed. It's going to change. It's going to enable us to do everything we want to do. But again, that's a conversation for another day. What about digital humans? Here we are. This is play the video. This is recreating the human being. Now, it's a really ethical question about how we're going to go forward. Play the video, please, CK. So it's going to be how we redesign humans and how we interact with people or non-humans that are going to interact with us. So next slide, CK. Yeah. This is lifelike, okay? It's becoming more and more. Imagine yourself being transported in this way and being interactive globally. Next slide. Play that video.
I'm Roman, a digital human brought to life by soul machines. With me, you can experience AI like never before because I learn and react emotionally like humans do.
Thank you. So what I've taken is telemedicine to the extreme. Telemedicine is great. What about pushing that boundary even further? What will it look like in the next 2 to 3, 5 years? I gave just a glimpse of that. It's shame only 20 minutes, become much more work, but hopefully that puts in context what the Zubin and John were talking about a little earlier. Thank you so much, CK.
Telehealth, remote health is not something new. It has been there for years. But then the question is why the adoption is not there still, right? So any thoughts?
Yeah, happy to respond to that. I think there were a couple of similar questions from others. So I was looking at them. They said, why aren't we moving quicker? Is there resistance from healthcare professionals? You know, what are the top barriers, right? That's the question. So I think probably break my answer into 3 things that we need to take note of. I think the first thing is that medicine is one of the traditional industries. I don't know if Shafi would agree with me on that. And it's different to the financial industry and other industries because it's very personal. It's about our body, you know, it's our health. It's very sensitive, I think. So that's the first point to note before I give my response. The second thing, I think, is the main resistance, in my opinion, is really because of fear. But fear of what? And I think it's fear of the unknown, but also the fear of potential negative clinical implications, right? And then the third point really is you have to think of multiple aspects from a monetary aspect, whether it's for the doctor, the patient, the provider, the payer. You know, do consultation fees increase or decrease? Certainly in Singapore, teleconsults are anywhere from $6 to $20. How would you expect a healthcare professional to make a living on a consultation of $6, right? From a medical legal negligence perspective, who is to blame? And actually in Singapore, we're quite advanced on this. There will be soon to be released guidelines on AI in health tech and med tech, right? Is the provider to blame? Is the company to blame? Is the doctor to blame? From an insurance perspective, do the current insurers today provide insurance to healthcare professionals to actually undergo and provide telecare? And then the question is really, what is sufficient in terms of what we can do in telemedicine? You know, where do you draw the line? And I think that's where the importance of guidelines is. And not every country has guidelines. And lastly, how do you actually measure the return of investment, which is what I talked about in my presentation there. And you know, there's a publicly available report that we put out, Digital Health Challenges and Solutions on the Return on Investment, right? But essentially, there are only a few things that we need to think about. Number one, are the high upfront costs really that high, or are they not? And if they are, is the return on investment actually possible? How do you define value, especially in today's day and age? I think Shafi, John, and I all touched on this consumerism and patient centricity. Today, value, if you ask a CFO, and I do, I often ask CFOs in hospitals and some of our clients, how do you define value? And you get the bog standard answer of value, you know, top line, bottom line, you know, the usual equation, right? But today, that is not what value is. Consumers expect, you know, greater convenience. You know, they want to determine where and how they get the care, as I mentioned earlier, right? So the definition of value has to change and has to be accepted, and it's difficult to get mindset change. There is a whole bunch of different infrastructure. Even within a single organization, you have multiple different systems in place. So it's not so easy to just say, hey, we'll implement a digital health solution. It doesn't work like that. And then lastly, we're just way too fragmented and siloed. Within organizations, between organizations, within a country, between countries, and the globe, we're a long way to go yet. So I think those are the main reasons.
How do you see the cross-border teleconsultations? Are the countries ready for it? For example, you mentioned about there was a surgeon in Mumbai and then London and different countries.
Oh, yeah.
Any thoughts on that?
Yeah, so cross-border. First of all, I think look, telemedicine has been a game changer. It's allowed equitable healthcare already, because all you need is a smartphone, you need computer access, which most people have these days in parts of the population, especially in rural settings. Look at Rwanda, for example. Rwanda is a country that's just, you know, still a low middle income country, but now does many millions of consultations per year on telemedicine. Who would have thought that only a few years ago? So it has the opportunity to change things entirely for access. If you look at the 5G model I was talking about earlier, Earlier, I think late last year, we saw a surgeon in the eastern province of China do remote robotic operation using 5G technology because of its low latency, and it worked quite well. And now people use that again in China, and in Milan, we saw an example being used recently. Go back 20 years ago, year 2000, there's something called the Lindbergh operation. The Lindbergh operation was the first operation that was done remotely, transcontinental. The surgeon was, I think, in New York, and the patient was in France, Strasbourg. Yeah, and that was done using the old ISDN lines. Can you imagine using those lines, that technology? But 20 years forward, look at it now. You know, latency of 0.1 milliseconds, imperceptible. Now we're seeing kind of this high bandwidth of 2-3 gigabytes per second, you know, on your smartphone. So it's changed dramatically. What was expected a long time ago, the future is now being delivered. So I'd say telemedicine's in, teleconsults are in. It's changed the framework that we're working in. It's democratizing healthcare, allowing more people to access healthcare. And why not? We're a global community, right? Look at the pandemic. It's a global pandemic that requires global solutions, right? That's what we've learned from it. Actually, what we've done now is actually learn about these global issues and solutions to work better as a community, both in industry and in healthcare. So I think those examples we've given are just a taste of what's going to come in the future.
Can I just add something, CK?
Yep, please go ahead.
But we have to remember as clinicians, right? So Shafi is going to be obviously in great demand globally, right? And he's way ahead of the game, right? But if you look at the average clinician, not just specialist, primary care physician, we must, I'm sorry to bring this up, and maybe this is where my clinical and corporate side come into play, right? We have to respect regulatory barriers, right? And regulatory guidelines. So when we talk about cross-border teleconsultation, as a doctor in Singapore, I'm bound by the laws and legislations of the Singapore Medical Council, as Shafi would be bound by the GMC. Now I'm, registered. I was with the GMC and got my registration in Ireland. Depending on where you're registered to practice, you must adhere to that country's guidelines. So there will be countries that don't allow a cross-border consultation because you have no jurisdiction over the care. Who's going to blame? So if I treat a patient in Indonesia today, right, can they sue me? It comes back to what the Singapore Medical Council will allow. So I think you just have to follow the legislations, and the way around it, however, if you look at most of the telemedicine guidelines that exist, they will state that you can provide a teleconsultation cross-border provided the patient is with their primary carer, for example. So say somebody wanted an orthopedic consult from me or a general surgery consult from Shafi, right? And they are in Bangladesh, right? Maybe the ideal and safe thing to do is to have them with their primary care physician and then do the teleconsult. So my point is just be aware that there are legislations around it and we need to adhere to those.
If I miss, I had this follow-up question to Dr. Shafi's point. One is the regulation part of it, as you rightly said that you're bound by the Singapore regulations if you serve in Indonesia or India. Touch wood, if something goes wrong, who do you pick it up? That's one regulation part. Second part is even the technology part. We talk about 5G, for example. If I'm doing remote surgery from London, but the 5G network provided by the local telco is not good enough, and something goes wrong, who will pick it up? So I think there are a lot of things, I think both technically as well as regulatory we need to address. And but the good part is the discussions are on. I think the kind of work with Dr. Shafi and all of you are doing it, I think we're going to push the regulators and the other ecosystem player to really move forward.
Yeah, I would like to ask this question to Professor Shafi and also Dr. Zubin specifically. And John, I'm sure you have come across this as well. So I'm running a medical device company in Singapore. And one of the things that involves us working with hospitals and collecting patient data. Now, when it comes to data, of course, we are building medical devices and we are interested in collecting and owning de-identified patient data to be able to build AI services on top of it and a host of digital services on top of it. However, at the same time, we are also interested in what hospitals have, which is a wealth of data like EMR, electronic medical records, which when we marry that data with the data set produced from our devices can do great things, right? The problem lies in getting access to that data. And I've been breaking my head over the last more than 6 months now, trying to convince hospitals to give me that access. And thanks to COVID, not much success. But I think that has to do more with also the willingness of the hospitals themselves to allow a third party to give access to their EMR. And I just want to ask all you gentlemen, what's the most efficient way to get access to that kind of data set?
And just quickly add here, but let's say if I'm the patient and I need to know that you are pulling my data. So there are like multiple parties involved, not just between you and hospital. The patient also need to be aware of what is happening with it. So yeah, please go ahead and help Abhishek to answer his question.
John, answer that question with your help.
Maybe I'll start, and then obviously you guys can chime in. But I think fundamentally it's about understanding what problem you're trying to solve as a starter. Okay, because just asking for access to the data without really clarity on exactly what you're trying to achieve with putting the data sets together, is not necessarily going to get the right outcome. Partnership working, from our perspective is critically important, because in most cases we don't even want access to the data. We want the third party or the health system to keep access to the data, and for us to basically enable the relationship and drive awareness of certain technologies to make it happen. But in my experience, having some of those partnerships in place, where you can pull on some of the bigger players, like the bigger corporates and some of the academic institutions and some of the accelerators, to help open those doors and get those relationships going. So, I'll shameless plug for the Healthcare FinTech Alliance in Singapore. That's exactly the purpose of that type of setup. It's there to try and enable the network, get you access to the right people, and coach you on how to have those conversations in an appropriate way around what problem you're trying to solve.
Yeah. Would you like to add anything, Dr. Shafi and Dr. Zubin?
Yeah, so look, data is such an interesting question. It's very relevant, of course. So I don't think as a society we've been mature enough to answer that question properly. We're running away. We're running scared with the data question. What does it mean? Who owns it? Who controls it? Who can access it, right? We share our data with Facebook every day. We ask no questions, we raise it, we share it. People are ready to share data. I'll give you an example. About a year ago, I had a conference, 1,000 people in the audience. I said, who in the audience is happy to share the medical data for the greater good of mankind? Everyone put their hand up. I said, okay, who's happy to share that data and monetize it if someone comes in and needs from industry? And people didn't know what to say. They weren't ready. Oh, I'm not sure, shall I? And there was complete confusion. We need clarity. We need leaders. We need government saying, this is what we're doing. This is the conversation we're going to have. There'll be some errors made. This is how we're going to share data. Have ownership. Let the patients decide on what level. For example, when you go to a website, it says yes or no. You want to enter all your cookies, all your data. You say yes. You don't ask it. What about if you had levels of saying, I will have just my anonymized data for these companies, or anonymized data for that, having a choice. You give people a choice, they can decide where they stand. And that's what we need to have, the conversation. And government's running scared, industry's running scared, and people like Abhishek are having problems because we are failing of having that sensible, intelligent discussion around data. We've just got to face it and confront it. It's not going away, right? Let's face it, right? So hopefully Abhishek, in 6 months, a year, people are brave enough to answer your questions and help you. We want it's about collaboration. We need people like Abhishek to come in, help healthcare systems like John, clinical data, research trials. We need them. It's a collaborative effort. We need industry, public partnerships to work properly. We need to enable that to be much better. In the UK, we're seeing a much better arrangement. It's getting better with NHS Digital, NHSX, and the Academic Health Science networks. We're seeing a slightly better arrangement. But it's that fundamental discussion that people are scared of that we need to have, and be bold. Zubin, what are your thoughts, man?
This is my favorite topic. CK, just stop me if I run over.
Go ahead. I don't have issue to extend the time.
Abhishek, I think we've met. We didn't talk about this though before. So the first thing that I would like to say is maybe put a question out to the audience. When we talk about clinical and health data, right? Especially in Singapore, this is one of my peeves. Who actually owns a person's health data? Is it the person? Is it the doctor who writes the case note? Is it the hospital that stores it? Is it the medical records office? And depending on who you ask, you'll get a very different answer. If you ask me, I've always maintained the answer. The patient owns the data. It's as simple as that, right? However, organizations are going to have policies in place, and you can either agree or disagree with them, right? So I think that's the first question that needs to be answered and put in black and white. Who actually owns the data? Because that will determine who can access it and what one can do with it, right? The next point you mentioned, you're knocking your head because it's difficult. It is difficult, but I can tell you, we work with a number of health tech startups. You know that health tech, we're involved in this space. We work with a number of health tech startups in Singapore, regionally and globally, and all of them have managed to get access to even government hospital data in Singapore. There is a way, and maybe we can take this offline, right? There's not a simple solution, but it is possible. But the main reason you're probably finding it difficult to do is, again, people are unclear. When it comes to health data, as Shafi said, we share more information on social media than anything else than our health data. And most people I speak to say, yeah, I'm happy to share it. Once you anonymize it, right, and provide security and ensure data privacy, there isn't an issue. So all I can say is, again, I can't disclose too much. I think keep an eye on this space in Singapore, because we are making a lot of headway in this space. And I think what you'll find over the coming months and years are solutions that are being thought of by government to actually provide startups like yourself to be able to access data, because everybody knows that's where the value is. If you have the data, you can do so much more. We're a bit slow, not just here, but globally. People are hesitant because of the potential repercussions. But health data strategy and clinical data strategy, I said it for the last 3 years, and I think this year is going to be the year that you see global changes on what people can do with data. And then lastly, just to share with you, the example I gave of that double jump PwC platform, we built it for one of the largest cancer centers in the United States. This was more than 7 or 8 years ago now, right? And it allows the person who puts in the data to provide access to whoever they want to provide access to seek that data in an anonymized fashion and do plenty with it. We've helped write clinical reports, pharma, payers, regulators, airline companies, retailers can access that data if they want, and it's monetized, and it's purely between the provider of the data and the recipient of the data. It has nothing even to do with PwC, but the platform exists, and we're not the only ones who have that platform. That these platforms for data exchanges exist globally. But like I said, I think this year onwards will be that big tidal wave that you see.
Yeah, I think there are a lot of acceptance will start coming in from the user point of view as well. Like you mentioned earlier, that to give a bad news earlier, it was not accepted to give through phone or person, but now I think it's okay. We have seen this lot of situation right now that people are getting comfortable. And in fact, I'm also seeing this data in some of those infographics that, as you rightly said, that we share a lot more data with Facebook. We just look at what we accept when we accept the application. So I hope, Abhishek, it helps you in some way. But I think there's still a long way to go, and maybe we should catch up one more time with Dr. Zubin and see.
Yeah, I will connect with him offline and try to connect with Mr. John and Professor Shafi also online,
Sure.
and move forward with our conversation. But I certainly learned the initial way to approach, the right approach, like John said, what do you want to do with the data, to have that framework very clear in mind, and then like Dr. Zubin said, who owns the data, and I think what Professor Shafi said, like, need people like us to come and approach them and ask for that data, so I kind of like get the triangle here, and I definitely want to implement that in the way I'm approaching.
What are the major challenges of working with startups through the lens of global healthcare provider? In addition to how do you manage expectation with the stakeholders internally? It was specifically pointed to you, John.
Yeah. Good question. I think there's many challenges, honestly, with building relationships between very large companies and very small companies. So I think the first one that I see, and this sort of harks back to what I just said, which I see this a lot, is be really clear what problem you're trying to solve. the number of entrepreneurs and startups that contact me with the latest technology that they've got, but are really unclear as to how that technology could be implemented to solve patient or healthcare system problems. So I think that's the first thing. And as we get better at that, then internally in the big corporates, if our senior stakeholders are really clear on what problem we're trying to solve as well, then they can grease the wheels a little bit. So if we get stuck because of a regulatory challenge or a legal challenge, if the senior leaders are really clear on what problem we're trying to solve, they can help ensure that we get unstuck in some of these situations. And I definitely found that actually with one of the examples I shared, the BeLive one. It was the first time Pfizer had ever introduced a wearable before. And we had incredible problems getting that over the line. But because, the senior stakeholders within our organization, and also we had some evidence from some very senior physicians as well that this was something that they really needed, we were able to, really focus on the problems and overcome them. Third one is evidence base, I think. So again, it's a bit of a chicken and egg situation sometimes with startups. We won't speak to them if they haven't got evidence to prove their solution, but then they can't develop the evidence to prove their solution without supporting, without working with a partnership and a big corporate. So that's where these accelerators become really important, because they are there specifically to help grow companies and give them experience, knowledge and capability to build out their solution, but in an environment which is okay to fail. If you come to us with a proposition around doing a $1 million deal, that's just not going to work if you haven't got the evidence base behind it. So yeah, healthcare is personal, and sometimes we get asked, why is healthcare not moving at the same speed as other industries? I think there's a very famous company that has a kind of ethos, which is move fast and break things. You can't do that in healthcare because people's lives are at risk. And so there is a reticence to move fast and break things in healthcare. And so building with an evidence base to start with, and ensuring that you've got all the right stakeholders at the table, it does take more time than in other industries, but obviously the rewards are significant for us. So I think this is where focus is going to be really important. And, I'm delighted to see what happens in the next 3 to 5 years.
So again, thanks, John, for joining this morning. I hope it was, as much as helpful it was for the audience, it has been useful for you as well. And I hope to invite you, because healthcare is a big topic. It does not end here, it is a start. So we hope to do a lot more sessions and discussions addressing healthcare challenges, both technical regulatory challenges, and how do we drive the ecosystem collaboration, which is also one of the key objectives as a company, as well as the initiative which we have, IoTSG, that we can't do everything alone, no matter how big we become. We do need to work with individuals, we do need to work with academia, we do need to work with startups, and let's pull it together, and this where I think we'll be successful together. So with that, again, thanks to everyone, and thanks to all the participants to stay with us for that long.